Martin Shapiro. Good to meet you, and I'm going to introduce you. Our speaker today is Sidney Hankerson, who is co-director of the Wellness Center at Columbia University, and is an assistant professor of psychiatry at Columbia University Medical Center. And he's going to be talking to us about partnering with Black churches to promote mental health equity. And he notes that African Americans with depression have more impairment, longer course, more severe symptoms compared to white Americans, and is going to be delving into socio-ecological factors that contribute to mental health inequities, and discuss the potential value of this church-based intervention to help to address this. So we're all looking forward to this talk, and it's great to have you on this side of the park, virtually.
Indeed, indeed. Thank you so much, for that warm introduction. And I'd also like to thank Dr. Morales just for just her support and just a wonderful invitation to be with you all today. And I also want to thank Grace Figueroa just for her administrative support and just making this process so seamless. So without further ado, I will go ahead and share my screen and delve into today's talk. So, as Dr. Shapiro mentioned, the title of my talk is Partnering with Black Churches to Promote Mental Health Equity. And before getting into the meat of the talk today, I just thought, I'd put forward a black screen. I mean, I am a psychiatrist, so I'm not going to ask you to project whatever you're feeling or thinking onto the screen, but I would like us all, in light of the events of this week, to just take 30 seconds, reflect upon what has happened, maybe just give our mind some rest from what has happened. And if possible, if you've been like me, you've been glued to the TV for the past few weeks while listening to Zoom meetings and speakers, because we're certainly in uncharted territory in this country. But if possible, just pull all of that on pause. And I'm going to set my timer for 30 seconds just for us to center ourselves and be present. So the timer is starting now. Okay. So that was, 30 seconds, and I hope that, maybe that allowed for some clear heads and just some release a little bit. Dr. Morales and I were talking briefly before, we started today, and she talked about, we both shared how exhausted we were. And I think that certainly all of us have been, for the past year, and certainly in this week, have been confronted with challenges and parts of this country and issues with this country that we never imagined that we would see. And so I certainly think that the events of the last year and last 2 days certainly are ripe for triggering certainly depressive and anxiety symptoms, as we've seen in the numbers nationally. And so I just wanted to go over some of the key themes that I think are at play in this moment for us now. First, letting you into my own feelings a little bit is rage. Certainly thinking back from last summer until even 2 days ago, I've been on an emotional roller coaster and have struggled with feelings of rage, of anger, of indignation. over certainly the murders of Black men, but also the storming of the Capitol, as well as, in my eyes, the duplicity of treatment towards those two sets of protesters. And then, of course, with COVID, that rage has been supplanted with a sense of despair for many communities of color in particular, of when is this going to get better? What can we do to address this? Despair and helplessness and hopelessness. And I think for many people that hopelessness has translated into symptoms of clinical depression. And we've seen a kind of burdened mental health system. And I'd like to hopefully take us through that arc to leave us with a bit of hope and faith as we're going into the weekend and starting a new year. I guess I thought about my two daughters. I have a 2-year-old and an 8-month-old. And so all of my feelings over the last several months have been centered about them and the world that they're in and the world that we are trying to create. And I think everyone on this call is passionate about creating an equitable world in all of its forms. So this is the arc certainly that I've been on, and I think many of our community members have been on as well. And hopefully we will go through the rage and despair and have some type of faith and hope for something better in the future. So with that, kind of broken my talk today into 3 main points. Briefly, we'll talk about some of the racial disparities in depression care, and then some of the work that we've done to demonstrate feasibility of providing church-based mental health services. And then lastly, go over this notion of community partnered service delivery and how that relates to task shifting and promoting mental health equity. So my clinical and research focus is depression, and depression is the #1 cause of disability worldwide. It's also the #1 cause of disability in New York City. So more people are suffering and they're impaired from depression than any other medical condition. The relationship between depression and race is a complex one. In nearly every nationally representative epidemiological survey that we see, African Americans have lower rates of lifetime depression and equivalent or slightly lower rates of 12-month depression. This data is from the National Epidemiological Survey on Alcohol and Related Conditions, and you can see that African Americans had prevalence of 8.9% of lifetime depression, lower than non-Hispanic whites, and 4.5 compared to 5.5% of 12-month depression. So although African Americans have lower prevalence estimates of depression, African Americans with depression are more impaired relative to non-Hispanic whites. These are results of the Sheehan Disability Scale, which looks at impairment in multiple domains. And you see, again, this is from the National Survey of American Life, another nationally representative survey, which show that depressed African Americans compared to depressed white Americans were more impaired in work, relationships, social functioning, and in overall functioning. So indeed, African Americans with depression have more severe symptoms and are sicker longer than white Americans. And despite that, we know that there are significant treatment disparities. African Americans in the United States. And these disparities have actually been exacerbated in the wake of COVID. And these disparities have actually trickled down to Black youth. For the first time in this country's history, Black boys between the ages of 5 and 11 have higher rates of suicide than white boys. So our children are actually taking their own lives. So there is indeed, as many people would say, a mental health crisis in the Black community. And I know that this group knows all about the socio-ecological framework and all of the many factors that contribute to barriers in care. So I'm just going to focus on 2 that I think are especially relevant to depression and mental health. One is physician misdiagnosis. This is a picture actually from a medical journal from the 1970s, advertising Haldol, which we know is a first-generation antipsychotic. And you see the tagline, assaultive and belligerent, and then a man who looks just like James Brown. So an Afrocentric looking man, assaultive and belligerent, and then cooperation begins with Haldol. So there's so much tied to this. The stereotypes of Black men of being violent, aggressive, and connected to psychotic symptoms. And I show this slide to show that even when using structured diagnostic interviews, Black and Latino men with psychotic symptoms are more likely to be misdiagnosed with schizophrenia compared to white men, who are more likely diagnosed with bipolar disorder with psychotic features or major depression with psychotic features. So we as clinicians have to own our part in these disparities in care as well. And then, of course, racism. Camara Jones put perhaps the most cited theoretical framework of 3 different levels of racism: institutionalized, which contributes to the socioeconomic inequalities in this country. So racism based on access to goods and services. Individual level racism, this is what I would think the general public talks about. Individual acts of prejudice and discrimination towards someone because of their race. And then internalized racism, which is not often talked about, but often one of the most dubious and just harmful impacts of racism, which is the self-doubt, the feelings of worthlessness, and often depression that happens to a marginalized group who suffer the impact of institutionalized racism. So those are just two of the contributors to disparities that I wanted to highlight. So now that we've kind of gone over those things that kind of contribute to the problem, I wanted to talk about why churches, I feel, can be such an important player in addressing these disparities in care. So there was a landmark paper that came out, in 2000, another nationally representative survey, which showed that among people who have a mental health problem, more people in this country, regardless of their race or ethnicity or their religious affiliation, are more likely first to seek help from a clergy person, a pastor, a rabbi, an imam, more so than they're initially to seek help from general medical internists or from psychiatrists. So mental health professionals is kind of a catch-all for psychologists and social workers. So, clergy and faith leaders are really frontline mental health professionals. And this is especially true in communities of color. In particular, African Americans are the most religious group in the United States by pretty much every measure that is used. 87% of African Americans belong to a religious group. The overwhelming majority identify as Christian, but there is a significant percentage who identify as Muslim. 79% say that religion is important, and 53% of African Americans attend church at least once per week. So given the fact that clergy are really the people to whom folks in the community go see when they're having mental health problems, as well as the frequency and importance and trusted nature of churches, we thought that churches could be, really excellent portals to engage people in mental health care. On the flip side, have to acknowledge how houses of worship have often been harmful towards people with mental health problems. In many, Christian traditions, mental illnesses are attributed to personal sin or a person's lack of faith. So the notion that you're depressed just because you're not praying enough or because you're doing something morally wrong. It's also important to note that many houses of worship have been harmful towards people who identify as LGBTQ. And so I think it's important to acknowledge both the opportunities as well as challenges in engaging with churches and promoting mental health. And with this knowledge of potential opportunity with challenges, I sought to kind of begin a program of research to address disparities in care. So one of the first studies that I did was to conduct focus groups with 21 pastors at a large church in Jamaica, Queens. 56% of the pastors were women. This was a highly educated group of pastors. Almost 90% had a master's degree or a doctorate. So this is a huge church, have over 20,000 members, and the denomination is African Methodist Episcopal. And I want to highlight three key themes or from those focus groups. So, when we're talking about the feasibility of providing church-based care, we asked the pastors what they thought contributed to depression in the Black community. And, one of the pastors just eloquently put it, slavery, then white supremacy, and institutionalized racism. All the things that we talk about in the Black community can cause depression. So depression in their eyes was not seen as a psychological or as a medical construct, but more a construct that resulted from institutional and structural barriers and social and economic inequalities. Another pastor talked about, the notion that that therapy and mental health care was just not something that Black folks did, suggesting this for that other culture, meaning it's something that therapy is something that white Americans do. And so acknowledging kind of the formal mental health system wasn't received as being receptive to treating Black patients well. And one of the clearest messages that the pastors gave me in conducting this focus groups was the importance of partnerships. One of the pastors said, Dr. Hankerson, we like you. You seem like a nice enough guy, but you have to partner with us if this is going to have any chance of working. You can't just come in here with your little medical degree and drop in and do a study and then publish it and leave. But you have to partner with us through every part of the process. And so this early study and some of the other studies that we did really shaped how we approach this, underscoring the impact of racism, the social factors, and the importance of partnerships. And so that leads us to kind of this notion of community partnered service delivery. And so when I mean with community partnered service delivery, it's really rooted in kind of four key principles. It's community partnered participation. So basically the principles of community-based participatory research, which I know many of you know and love, implementation science, task shifting, and then building capacity within our target community. So these are the key elements of community partnered service delivery. And so community partners research, which was derived from community-based participatory research and created by Ken Wells, a psychiatrist at UCLA, and the late Loretta Jones. And it's really focused on, community and partner empowerment, two-way planning between academia and the target community, equality and respect for diversity. And studies that have employed, community partner methods have shown and led to increased participation among people of color, increased trust with the research process. It builds capacity in the target community, and it's been shown to reduce disparities. They did a large cluster randomized controlled trial in LA and showed improved depression symptoms and improved treatment seeking in the largely African-American and Latinx participants in their study. And so building on that, as part of my K Award, I actually kind of used the methods of community partner participatory research to create a community coalition for mental health, which is basically an advisory board that provides community-based leadership for all of my studies. This is a group of pastors, of community members, of clinicians, of people who have lived experience with depression, with opioid use, And we have come together since 2014 to create this group, and have decided to focus on three things. One is promoting mental health equity. Two is reducing depression stigma. And then our third goal is to really build and foster community and academic partnerships. And so here's a quick slide just showing some of the members of our coalition a couple years ago when we kind of formalized our partnership. So this is a shameless plug. I truly believe that the strength and success of our coalition is built on the diversity and strength and passion of our members. And we're open group. So if anyone is interested in attending any of our meetings, they're all being held virtually now through Zoom. Please feel free to contact me. I'd love to have you participate in some of our meetings. And so one of the, proudest moments of the work of the coalition is that in partnering with local churches to build capacity and provide mental health services, one of our key church partners, 1 Corinthians, this is actually a picture of the ribbon cutting ceremony where First Lady Chirlane McCray, New York State Senator Brian Benjamin was there, and Manhattan Borough President Gail Brewer. But this clinic is staffed by psychologists and social workers and provides community members with up to 10 free sessions of evidence-based psychotherapy. They mostly do trauma-informed CBT, as well as interpersonal psychotherapy. We've also developed a relationship with them through Columbia, where people who need medication management can be seen, for free through residents in our department. And so this is one of the crowning moments of the coalition's existence. And I have a quick video to show some of the things that the Hope Center is doing.
Crazy. And then from the church's perspective, you always heard the whole notion of, well, there's some things you battle with where you can pray it away. If you pray and seek spiritual guidance, these things will go away. And I don't believe that. Counseling, group counseling, there'll be workshops and seminars. We look at them as innovators, not persons who have issues, not clients who are wrestling with some kind of disease, but innovators who are finding creative ways and creative paths to their own wellness. You no longer have to suffer in silence. We want to take that stigma off, and that we want to create paths of wholeness for people who battle in silence with mental illness.
So I actually was at 1 Corinthians this morning. Pastor Mike is actually being interviewed by CBS today. They are giving away 50,000 free meals. They have a weekly food bank, and they're actually giving away 50,000 free meals to New Yorkers today. So you may see that on the evening news. So kind of the last part of kind of community partnered service delivery is this notion of task shifting. And task shifting has been used a lot in international studies of depression. primarily in worldwide, but a lot of the research has come out of India in primary care clinics. And task shifting is the notion of training non-mental health professionals to do some basic screening, referrals to a higher level of care for patients who need a higher level of care. And so we have created an institute for training community health workers. And all of the institutes, all of the community health workers that we have trained at our institute at Columbia have been recruited from churches in Harlem, the Bronx, and Brooklyn. And the institute is called In Touch. And so we have put together an 8-week training program. It's based entirely on the CDC model of training community health workers. The community health workers are trained how to take blood pressure. I teach them how to screen for depression with the PHQ-9. They're taught motivational interviewing, and they go over patient navigation. They're actually registered with the New York State Office of Mental Health as health insurance enrollment officers. And to date, we have certified 124 community health workers from 42 Black churches in New York City. They have screened over 2,000 adults for blood pressure and have enrolled 110 people in the New York State health insurance marketplace. And so this is the model that we have created, leveraging the trusted role of these faith-based organizations. And so who are the community health workers? I'm so glad you asked. So our community health workers are predominantly women, and this actually represents kind of the church. The average age is 61 years old, and you see really a wide range of educations, from college graduates to less than high school, graduates. So really representative of the community. This is just a picture from our wellness center where we're doing one of the trainings where the community health workers are kind of learning how to screen and take blood pressure. So we've leveraged the trust and the role of the community health workers. I recently got my first R01, which is a cluster randomized controlled trial that involves 30 Black churches. The community health workers from these churches are going to be the interventionists in this study. They will be screening congregants for depression with the PHQ. And just like in clinical samples, a positive depression screen is considered a PHQ-9 greater than 10. If anyone screens positive with the PHQ, they will be referred either to motivational interviewing, which the community health workers will deliver up to 5 sessions of MI, compared to kind of referral as usual. So this is the current study that we're doing. And through all of this community-based work and the community-based service delivery, we've kind of delivered this model of community engagement called Faith, that kind of highlights some of the 5 steps that we have identified as being essential in creating strong relationships with the communities with whom we work. And this is an iterative process, so it's not necessarily linear, but these we think are the 5 steps. So 1, faith, the F starts for forming a strong partnership. In terms of my relationship with Pastor Mike and the churches with whom I work, a lot of my time is spent in the week at church meetings. I've eaten a lot of dinners. I've done a lot of presentations, and I've made a lot of referrals for community members who are asking for referrals for family members needing mental health services. And so I think really being present and being committed to the partnership is the first part. And then assessing the community's needs. We've done that through qualitative methods with the focus groups as well as quantitative measures. So we did the first, church-based depression screening study with the PHQ-9 and found high rates of depression. So assessing the community's needs. And then identifying leaders who will support. In the church, obviously, it's the pastor. You got to have the support of the pastor to have any chance of success. And then really taking time to set the context. I really think that's crucial, especially as it relates to mental health conditions, which still are highly stigmatized in communities of color in general, and in some faith settings in particular. So taking time to set the context, have key leaders in place. And then lastly, honoring the community's culture. So honoring the racial and ethnic cultural needs of the church, as well as the denominational needs. So this is our kind of model of community engagement. So, in summary, reducing racial disparities for depression is really a complex issue. There's clearly no silver bullet, but as we all know, we think it's going to need multi-leveled solutions. We've demonstrated that churches are well suited to promote mental health equity because of their trust, because of their access, because of their history of health promotion, and because of their ability to have kind of task shifting workers, a workforce available. And then community, partner service delivery, really embodies principles that can be scaled in under-resourced communities. So that is the conclusion of my formal remarks. I certainly wanted to leave ample time for questions and answers. Yes, Dr. Morales.
Hi, you can see me. I can't see you yet. That was wonderful, and I'm going to tweet about this talk because I think it's so important and so wonderful for us to hear. And there are some of us, not everybody that is involved in faith-based efforts here was able to make this call, but luckily we're recording it, and I want to make sure that we share it with them. I'm interested, given, obviously we all have COVID on the brain. Given the intense involvement of the community in faith organizations, and now the cutoff from faith organizations, except, for the most part, except electronically. I know some people have been meeting a little bit, but I know that also people are very wary. In fact, yesterday I was just talking with my patient about her, her loneliness, her missing her church because she's afraid to physically go into the building, of course. And, I think churches vary in their technologic sophistication and access. And also, it doesn't necessarily obviously substitute for the visceral physical experience of being in the community physically together. So I'm wondering what you're speculating or already seeing in terms of what, the impact of this terrible thing has been, especially because I think our communities and the people that you're working with certainly have been traumatized and bereaved.
Yeah, that's such an important point, Dr. Morales. COVID has absolutely decimated so many of the churches in Harlem with whom we work. Several pastors I know have passed. Actually, one of the community health workers died. And so everyone has been affected by this. And you're absolutely right that so many of the people that we hope to reach are struggling with the social isolation of not being able to go to church now. For our study, we've made everything remote. We're not going to be doing anything in person, even if church is open, until at least next year. And so that was a decision that we made just to protect everyone. So all the community health workers now are being trained in Zoom. They have to do city training and all that kind of stuff so that they can have HIPAA compliant Zoom accounts. But it's a real challenge. And so we are really worried about our ability to be effective in this pandemic. So we don't know. We are taking precautions. We're making everything remote. But this study just started in June of last year. So we're still hiring staff and going to start recruitment in March. But we don't know. But it's definitely a need. I will say, I think that what COVID has done, it has in some ways reduced the stigma associated with seeking mental health care, because so many people know someone who has died from COVID. And so many people are just so anxious about either getting infected or becoming sick. So in some ways, people who would normally not want to seek care do want to seek care. And so we are hopeful that we'll be able to meet some of those needs virtually.
I have a comment and a question. First of all, I was very touched that you mentioned Loretta Jones, who I knew very well. I was at UCLA previously.
Oh, wow.
And she was a woman who took no prisoners.
Yeah.
She took down all of us when we thought we were doing community type stuff. It was never good enough because we were never really engaging and listening to the community to the extent that she felt that we needed to.
Yeah.
Doctors almost always think they they know the way. So she was a wonderful educator.
Yeah.
And it was, working towards a more perfect ability to engage seems to be what the process has to be. The question I have has to do with, first of all, I think it's wonderful that you're doing this work. You're taking on something that's really difficult. And, but it's really important to take on really difficult things like you are. But let me ask you this. African-American women go to church more than African-American men. And a program like this is likely to be, if it's effective, it's likely to be more effective in reaching women than men. And have you thought about whether there ought to be some other things that one should do beyond churches to reach the men? The other thing, you did mention the LGBTQ community. Some of the people may be less engaged in community churches. And if they're engaged in community churches, they may be rather reluctant to talk about some of the things that are sources of depression for them. What are your thoughts?
Sure. So I'll go in order. And first, thank you for your comments about Loretta. She truly was a force to be reckoned with. And I think really a pioneer in, community engaged research. So to the first point about engaging men, you're absolutely right. Churches on average are 60 to 70% women. And that is reflected in who our community health workers are. However, and I didn't show this, just in the interest of time. I thought there would be a lot of questions about everything happening in the world. But we, conducted a study with 3 different churches. That was the first study to use the PHQ-9 to screen for depression in churches. And in our study, we did 1 church in Brooklyn, 1 in Queens, and 1 in Harlem. And we were able to recruit 44% men. And the men actually had a higher rate of positive depression screen than the women. It wasn't statistically significant, but 23% of the men in our sample screened positive for depression, and 18% of the women did. And I'm happy to, share that paper with you all later. But when we looked at that, the men in our study were more likely to have a lower income. They had lower education, and they were more likely to be on disability than the women were. And so, we really thought that, at least for the men who we were able to screen, we think because many churches have men's ministries where they have programs focused specifically on engaging men, we think that it can provide a context of safety and security for men to talk about some of their emotional problems and screen them. But to your point, there's just not a lot of brothers that go to church. So I've actually partnered with Joseph Ravenel at NYU to do some barbershop-based studies around men. And he and I and Michael Lindsay are in the process of submitting a grant on some barbershop-based mental health interventions.
Joe was a fellow here.
Yeah, so I know he has some roots to Cornell. So yeah, so
Love Joe.
yes, no, I love him too. So we're actively working to do some barbershop studies specifically focused on Black men.
So Sidney, I haven't had the pleasure of meeting you, but what a wonderful talk. Thank you so much for sharing your work. I've been looking for opportunities to try to scale up an intervention that we did when I was at the University of Alabama at Birmingham with a population of mostly women, but they were all African Americans living in the rural Black Belt. And it was a study that was inspired by lady health workers in Pakistan. That was one of the most effective behavioral interventions I've ever seen. That was run by Atif Rahman, a pediatric psychologist, psychiatrist, who was trying to combat maternal depression, postpartum depression. And the intervention never once mentioned the word depression. And it was entirely focused on the health of the child. So how do we give this child the maximum chances of success in life? And it cut the rate of postpartum depression in half. So
Wow.
It was incredibly effective, one of the most effective interventions in all of medicine. I mean, there's very little that we can offer people that cuts things in half. So what we did is we adapted this intervention for diabetes and chronic pain, because one of the things that we noticed in doing our diabetes studies is that a whole lot of people with diabetes are in chronic pain, as much as 70 to 75%, enough for it to interfere with daily activities. And of course, one of the big emphasis of diabetes self-management is physical activity. So we tell people they're supposed to be physically active and they say, well, I'm hurting. And we say, oh, well. So this was a CBT-based training intervention that was very much in the context of diabetes and helping you to get physical activity despite your pain. And because it was CBT, it was extraordinarily effective at improving depressive symptoms. And as you know, people in chronic pain are at very, very high risk for moderate to severe depression. So one of the things that really intrigued me about this was it was a 10-week long intervention, 12 weeks long. It had a durable effect a year later. So it really, the lesson as a primary care physician was, it's all one person. So, we tend to be very focused. Oh, you have depression. Oh, you have diabetes. Oh, you have pain. So we're going to send you to the endocrinologist. We're going to send you to the neurologist. We're going to send you to these people. And this was sort of this wonderful package that focused on something that wasn't stigmatized, but very effectively treated. As you know, CBT and mild to moderate depression, it's as effective as medications. And we constantly are pushing the medications because we don't have the resources for CBT. Right. But I wonder in that particular community, what your thoughts are of focusing more on like health, overall health, the importance of physical activity. This is something that can get you moving and sort of as a byproduct, which could potentially have been the major target, it helps people with depression without ever having to engage a mental health professional, without ever having to get this diagnosis. We also use the PHQ-8. We had to remove the suicide question, which a lot of studies have to do. But I would love to hear your thoughts, and maybe we could schedule a follow-on conversation to talk about what the potential would be of disseminating something like this in your settings.
Yeah, first of all, thank you for your comment, Dr. Safford, and your research is that's fantastic. I think it would be very well received and transferable, in that setting. When we've had a lot of community mental health symposiums, we don't use the word depression. We talk about stress in the title. We find that's more acceptable to people. We talk about wellness, and we talk about, holistic health. So I work at a FQHC in Harlem that's, doing collaborative care. So I totally understand and work with internists and really focus on, holistic health. And to your point about diabetes, absolutely. They're really hurting have a lot of comorbidities.
Mm-hmm.
So yeah, I mean, I'd love to learn more and see what's possible in terms of collaboration.
Oh, I'm gonna jump in. Sorry, I wasn't sure whether I was unmuted or not. Okay, hi. It was good to hear about your research. Thank you so much for, and about your work, which frankly goes well beyond research, for sharing this with us. So I'm coming from a bit of a different perspective because I am a political scientist by training. So so one question I have is about the research process, and about your sort of positionality within that process, and maybe just getting a sense from you of best practices given that. And then I have a completely separate question that may be a bit off the wall for you, but I'm sure that you can roll with the punches. The first question is, and I loved hearing about, the work, and especially the work you're doing in Queens. I'm from Queens and my heart is in Queens. So I think that's excellent. And I wondered about how, I think about the kind of model that you laid out, this faith model, right? And when I think about some of the different components of this, like forming the partnership, right? Assessing the community's needs, or even honoring the community's culture, it strikes me that like not every researcher is equally positioned to be able to even understand or conceptualize how to do those things, right? And so I'm like, okay, yeah, I mean, when I think about like different churches that I went to growing up in Queens and Brooklyn, like I could, the vast majority of researchers that I know, I envision them in my mind trying to walk into these churches and form a partnership so that they can do their research for their big grants. And it's like, that could easily be a disaster. Clearly it's not with you, but I wonder about what your ideas are around best practices as far as like who is best suited to do this research, and or how to navigate these spaces, particularly if you don't share, for example, the racial identity with, right? So in a lot of these churches, I imagine like as a Black man, like at least in that way, you're sort of fitting right in. And that this could look really different if that weren't the case. And what would that mean for the approach? And what does it mean for the model of community engagement that you're articulating more broadly? So that's one question. And the second one is really quick, which is, again, I'm a political scientist, and I've been doing some work on the political side of things, at trying to work with different people in let's just say in politics, who are thinking right now about how to construct like a public health corps, or how to expand our the kind of number of public health workers in the country, and how to leverage some of what's going on right now to develop the public health infrastructure more broadly. And we've been talking a lot about the role of different community organizations, the role of institutions like churches and what have you. And I wonder whether, and one of the things that comes up again and again is that that we may be able to leverage these different institutions and organizations to get support for the policy that we're trying to pass, right? To develop the kind of political support that we need in order to really expand the infrastructure of public health. And I wonder, and there's also a long history of Black churches in particular being engaged in political struggle, right? Now, that's not what you're doing here, but I wonder if there is a possibility, or what you think about the role that these same institutions that you're engaging in these interventions, what role they play in making it possible for these interventions to be scaled up in a really wide way, which can only happen through the political and policy process, right? And the same way that these churches are a potential locus for creating opportunities for people to get the mental health interventions that they so desperately need, they're also a potential locus for bringing people into the kind of policy advocacy realm, so that they have more resources for more kinds of interventions like that in those communities in particular. And I wonder if that is ever a thing that emerges as you're doing this really, specific mental health work, that it connects up to the larger political process in ways that can empower the folks that you're talking about, even beyond the sphere of mental health directly.
Yeah, thank you for, such wonderful questions. I'll start with the second one first. So I and definitely want to connect with you after this, because I look at through this as everything through a policy lens. I was telling Dr. Morales that Cameron Webb is one of my best friends, another Cornell person doing tremendous work in the policy realm. So how we're trying to do this, I always think about how can these things be scaled and sustained, right? And so one of the things that we're doing is trying to collect cost data on everything that we're doing for this study. So the community health workers are actually being hired as Columbia employees, so that we'll be able to create a business model for this. They're getting paid as Columbia personnel, and the intervention that we're doing is it's billable through Medicaid. So they're going to be doing, screening, brief intervention through MI, and then referral to treatment. And that's a billable service through Medicaid. So my dream is that if this is effective, of course, scientifically, that we will have created, a business sense, a business model for kind of hiring this lay workforce, training them, and allowing them to bill for services to generate income and sustain their employment. So that's one way. But I think that the other thing is that, we've had multiple meetings with the New York State Office of Mental Health, Commissioner Ann Sullivan. I've had multiple conversations with Shirlane McCray in the mayor's office to think about how these community-based organizations and interventions in their settings can be leveraged through policy. Certain haven't come at a answer yet, and would love to learn from your expertise in this area. But I think that's such a crucial, piece of this is the policy piece. And then lastly, I think all of the pastors with whom I work see mental health in particular as a social justice issue. Understanding, just looking at opioids now, and now that Black New Yorkers are dying from opioid overdose at a higher rate than white New Yorkers are. But there's no access to buprenorphine and no treatment. So those are all policy issues. And so would love, to learn more from you, about how to leverage these things. The first part about kind of the model, the faith model, and how to form a partnership, and how does racial identity and our intersectionality impact these things. I will say that because I am a Black man, and I will say I am a Christian, because of those identities, that has been helpful to me. But I will also say that my identity as a psychiatrist and a researcher has been hurtful in some ways. And some pastors and CBOs with whom I've worked initially said, yeah, we'd love to work with you. But then when we followed up and we needed the letter supports, things went quiet. And when I talked to people on the inside, it was, well, they had a bad relationship with Columbia. They don't really believe in psychiatry. And so just because I'm a Black man does not mean that I get a pass. So I think that's number one. I think number two is, I think folks in the community care about and can tell very quickly who's doing this because they care and because it's something that they see as their mission versus it's something that they want a publication for. And so one of my actually mentors is Elizabeth Cohn, who's a white Jewish nurse who has been working with Abyssinian Baptist Church for almost 20 years now. And she calls Calvin Butts and his wife whenever she, needs something from them, and they give her stuff much quicker than they give it to me, and it's because I think she's worked with them so long, and the trust that they have, with her. And I'm getting to the point of being able to have that relationship with them. But I think it really is about the trust and being present, in the communities. Has as maybe more weight or as much weight as racial and ethnic matching.
Thank you for those responses. We should definitely connect. So much to talk about.
Indeed.
I knew everyone would love each other. I live across the street from First Corinthian, But I think I told you this maybe when we met, Sydney. I was a community health worker as an undergraduate, as part of something that the Harvard School of Public Health, a course that the Harvard School of Public Health had that I was able to cross-register in, which was called the Community Health Improvement Program. And part of it was about, being embedded in a community-based organization, addressing community health issues. And so, we're also very interested in this issue of training and young people. And so I think there's a cross-section possibilities there as well in terms of having our young people involved in this effort and along the lines of this idea of scalability.
I love it. And as I'm looking, I'm realizing I didn't answer, Dr. Shapiro's question about the LGBT. And when you said the youth, that made me think of it. So I do want to, I think that's such an important topic, especially the intersection of houses of worship and folks who identify as LGBTQ. So, 1 Corinthians in particular, 30% roughly of the congregation identifies as LGBTQ. So we have specifically been very intentional about engaging folks who identify as LGBTQ, at that church as part of our studies. And the Community Coalition has also been very intentional about trying to understand what churches, even if they're not explicitly open and affirming to folks who identify as LGBTQ, at least are sensitive and are not harmful in theology, word, and actions to folks who identify as LGBTQ. So it's something that we're very cognizant of. It's something that I think needs, even more attention. And it's something that I'm really passionate about, addressing.
Hi, Sidney. This is Linda Nabobi. Sorry, I can't turn my video on, but I hope you remember me from our CBPR course at Columbia.
Of course.
Yeah, good to see you, and thank you for this amazing talk. I'm really, really inspired to use what we've learned in our course to do some work. A quick question I have for you is, during this time of COVID, I have found more difficulty both in research and in my clinical work to connect with minority patients, just mainly due to technology issues. People are uncomfortable, using Zoom and other technologies because they just don't know how to use it. I'm finding that more with my patients who are minorities. And my question for you is, do you have any tips on how you've been able to reach out to people and also maintain relationships with the organizations that you have these partnerships with, during a time when we cannot see people in person for safety reasons?
Yeah, first of all, Linda, great to hear from you again. And I think that in terms of the technology piece, it's a huge issue, and it's my biggest fear with the study currently, that it's really going to limit our ability to reach people. I think the good news is that the PHQ, there's a ton of evidence with it being done over the telephone. And based on my clinical experience as well in using Zoom and doing sessions through telephone, have had some success in communicating with people just over the phone. And some people are much more comfortable doing things over the phone. So we are going to be training the CHWs how to do the screening through Zoom and over the telephone.
Okay, thank you.
Sure.
I would love to, as we're rolling out our COVID vaccination community education plan, I would love to work with you on that. Obviously, your network will be great. And, it's that we're working with the Department of Health, but also the hospital and its network in trying to get the word out to empower the community to make decisions, because there is a lot of vaccine hesitancy. And I do have a sense of extreme urgency and anxiety about it, but also, I've been doing a lot of trainings internally with our staff who have a lot of vaccine hesitancy within the hospital. And of course, a lot of the staff of color in particular are very hesitant. And it's been very interesting just to especially this, making sure that people are 100% aware the importance of being non-judgmental, supportive, and empowering for people's own decision making. So I really am, look forward to maybe working with you on that. I'm as the pandemic escalates, I'm
Yeah.
kind of freaking out. So
Yeah,
I
absolutely.
love to partner about that.
Absolutely.
This has been an absolutely wonderful and so stimulating a presentation. We're at the end of our time, but I think we all hope that we're going to have many opportunities to interact with you and to work together to heal the community. But thank you so much for your great presentation.
Thank you. My pleasure.
Bravo, Sidney. Thank you.
Thank you all. Have a great weekend.
Stay safe, everybody.
Take care.
Bye.